You guys all so much for coming today. We're so excited to host three amazing UD faculty as we open doors to racial disparities within the healthcare system. Tonight's topics will range from mistrust in minorities to external and socioeconomic factors that impact health outcomes, health policies, stereotypes, and so much more. So with that being said, let's introduce our guests tonight. First, we have Dr. Latoya Watson. If you want to share a little bit about your role at UD, your connection to the Be Positive Foundation and UDance, and any background or experiences that you have within diversity and inclusion, and then we'll pass it off to Dr. Knight and then Adam. Take it away.
Hello, everyone. My name is Dr. Latoya Watson. I'm the Assistant Dean for the Associate Arts Program, and I oversee advising across 3 different campuses. A lot of my work is focused on equity and inclusion work. And so, in fact, my research was on equity mindedness and academic advising. So that's my work. My daughter is Be Positive hero, Mariah Watson. So she's been a Be Positive hero for the last few years. I see Joe McDonald is here. He came to the hospital when she was diagnosed. So I have very fond memories of my experience with UDance and Be Positive. So I'm happy to be here tonight to have this conversation with all of you.
I'm Erin Knight. I am faculty in the Biden School of Public Policy and Administration. I teach public health, undergraduate public health, and then I also teach our Master's of Public Health program. I actually worked in public health for about 15 years before I started teaching, so I have a lot of practical background and teach from that kind of perspective. But my research and my passion really has always been about issues related to health equity, health inequities, social determinants of health, and more recently, racism within the health system. And so I'm really excited to be here and really appreciate the invitation and glad to see so many people joining us. So thank you.
All right, good afternoon, everyone. My name is Adam Cantley. I serve as Dean of Students at the University of Delaware in our Division of Student Life. This is my 10th academic year working at UD, number 10, not like any of the rest, clearly. I think starting in my second year, I was approached by the students who were the leaders of UDance to come on as the faculty staff advisor for UDance, and have been a faculty staff advisor for UDance ever since that point. So year 8, 9, I don't know, with UDance as an advisor.
Awesome. Thank you all so much. So just a few logistical things before we get this discussion rolling. If any of you have any questions during the discussion, you'll notice that you can only chat the host, Maria Lilly. So if you have any questions for Dr. Watson or Dr. Knight, you can feel free to chat Maria, and she'll be sure to relay that question to Adam, our mediator for tonight. We may not be able to get to all of your questions, but we will do our best to get through all of them. So with that, I'm going to hand it over to Adam, and let's get this rolling. Thank you.
Thank you, Sarah and Maria. And thanks to, it was not just Sarah and Maria, a lot of our students on UDance worked to put this together. So thank you all for doing this. As an advisor, I was really excited whenever UDance started to talk about, like so many other organizations, how racism, white supremacy, social justice impact the work that they do. And when they were having conversations, you know, they said that they wanted it to be mission focused in their mission around childhood cancer, healthcare, things like that. So that's where this kind of came from their discussion as students. So I think my first question is a general one. I'll start with Dr. Knight and then Latoya, Dr. Watson. So it's going to be hard for me to call Latoya Dr. Watson. We have hung out so many times together in classes and things like that. We will talk about your experience as well. But Dr. Knight, why is it important to talk about diversity and inclusion in relation to healthcare from your perspective?
Oh, wow. Health is, I mean, it's supposed to be a human right, right? So UN Declaration of Human Rights more than 60, 70 years ago said health was a human right. And in the United States and many places around the world, but you know, my concern is in the United States, it isn't, it still isn't. And so when we think about health inequities within sort of population health broadly, but then also within the healthcare system specifically, we know that not everyone has that right to health. And so, you know, I think it's incumbent upon us to remedy that. I mean, we're the most advanced nation in the world, right? And not everybody has even access to healthcare, let alone quality healthcare. And then we see these huge disparities or inequities in health status. So from my perspective, it goes all the way back to that just really basic fundamental idea that we have not even come close to assuring health as a human right.
Latoya, your thoughts?
So when I think about health disparities, I think about in health in general, I think about the inequities, and I always look at inequitable outcomes, particularly because when you just aggregate data, you can see the disparities in outcomes when it comes to Black and brown bodies. I know for infant mortality rates, they differ greatly. Mortality rates in general, life expectancy. So it's a major concern. And when people talk about diversity and inclusion, I always remind everyone of being very intentional about when we talk about diversity and inclusion, because diversity is this word that we throw around a lot. And it becomes where it's not as powerful because you don't really define what diversity means, because diversity, it could be diversity of personalities, because at the center you are either introvert or extroverted. But diversity also includes age, gender, socioeconomic status. It includes sexuality, sexual orientation. It talks about your gender, your race, ethnicity, and those all impact your diversity. When we talk about diversity in terms of having specific outcomes, you have to be very intentional about how you approach diversity. Meaning that if you're saying that you are looking at improving health outcomes, you want to also think about how you diversify the workforce and having more doctors that are of color. Particularly if you think about Black male doctors, we have fewer now than we did have it back in the 70s, things like that. But also have the conversation of inclusion, because you can have diversity that looks good, but when you bring those people into your organization, are they included in the conversation, or are they dismissed when they say things? Are they in roles where they have power to make decisions, or are they just in the background? Because you look at diversity, inclusion, and equity across the United States, whether you're looking at legislator, whether you're looking at CEOs, that's not representative of the population. When you look at Supreme Court, it's mostly white males. Is that the population? No. So I think that's something to think about when you think about health disparities, and looking at it not only in the health system, but how does it look like in the entire ecosystem within the US as well?
That's great. I think what I appreciate about both of your thoughts is talking about this from a historic perspective, right? So I mean, America was built from racism. It was built from slavery, and the systems of racism and slavery still filter into the systems that we see every day, right? That's a reality that we can't ignore as people in the United States. So when we're looking about how systemic racism impacts healthcare today, what are some of the things that come to mind? I think a lot of people want to think about this is how it used to be, or maybe this is how it was, but I think it's really important for our students and all of us to talk about how it is today. So thoughts from either of you about that question?
So there's a few factors. When you just talk to you about the entire ecosystem, when you think about health disparities, it includes economics. If you look at it historically, being blocked out of housing that actually accumulated wealth, being blocked out of education with the GI Bill when it was expanded, like not having education. So then you look at poor communities. So you have disproportionately people of color who are poor, but also recognizing that even with someone who's middle class like myself, being Black and middle class, I have poor outcomes health-wise as someone who's white and poor. And I think it's really important to recognize this as well. So there's the issues of like the economic disparities that are impacting it, but also just because of racism, where you have different outcomes for people of color. So when I think about like my own personal stories, my own personal traumas, I think about the birth of my oldest daughter. So for her, when I went to the hospital, they ignored my pain. I was in active labor. I had already gone to the hospital before because I was high risk, and that they noticed that they knew that when I got to the hospital, I was already dilated, and they ignored me. In fact, my water had broken. I was wet, and they just gave me a pad and told me to go to the side. And so that stayed with me, and that is. I know others who have the same story. When you think about infant mortality and mortality of women in childbirth, the numbers are disparate for Black women. And that's not just with socioeconomic background. So I'd be better off if I was poor and white, because I feel like this trope of being a strong Black woman impacts how we treat Black women in the healthcare field. So that's just one example of how it plays out.
Yeah, and I think Dr. Watson's experience is representative of Black women generally, and that's what the data says. We know that infant mortality is one of the biggest, most important determinants or indicators we use to understand the health of a community. And Black women experience infant mortality at 2.5 times the rate of white women, and that has been consistent over decades, right? We're not making progress. So we can talk about this as a historical phenomenon, but nothing's gotten better. Many things haven't gotten better. And in some areas, the disparity has actually gotten bigger. So we have to think about this. The historical context is critically important because not only, have we not been able to remedy some of those, 400 years of oppression, but we actually have this sort of accumulative effect. And so when we think about even sort of income disparities that relate to health disparities, right, we know that that the income gap has gotten wider because it's been this generational accumulation of oppression and lack of investment in many poor Black and brown communities. And so we're seeing that the problem get bigger, not smaller in many areas. And maternal mortality is an area where we're actually seeing numbers grow in Delaware in particular. The rest of the world is making progress on maternal mortality. Women shouldn't die in childbirth, but in the United States, that number is actually growing. And experts point to sort of racism within the healthcare system, but even more broadly, racism sort of writ large as an underlying factor.
Yeah, thank you. Thank you both for sharing that. And thank you to Latoya for being vulnerable and sharing your personal story. That's very powerful. And I appreciate you doing that with especially people on computer screens you might not know. When our students began to really look at this topic and have this conversation, they started seeing a lot about how there is this historic mistrust from Black and brown folks when it comes to healthcare and with doctors and things like that. Dr. Knight, could you maybe talk a little bit about maybe why that exists or why that seems to be a narrative that is out there?
Yeah, sure. So again, research shows that, and I'm going to have to come from a research perspective, and so I apologize. But I think it's important for us to understand that the research shows, and there have been very real abuses of Black and brown people over those 400 years, since the beginning of slavery in the United States. And we know, for instance, I would like to talk about infant mortality and maternal and child health, because that's just such a key area, an area we could actually make a difference and move the needle. The doctor or the founder of sort of OBGYN, the doctor that's sort of credited with, being this world-renowned expert in maternal and child health and in obstetrics and gynecology, experimented on poor Black female slaves. And so, right from, the very beginning, we had these examples of abuses. And then much more recently, we have similar examples that, again, back to that issue of we haven't necessarily made that much progress, right? So in 1930s, 1940s, the US Public Health Service, the government of the United States, conducted the famous Tuskegee syphilis study, in which, and I'm sure many people know about it, I won't go into all the detail, but even after we identified a cure for syphilis, Black men were denied that treatment. And so, we have Henrietta Lacks. I mean, there are just so many examples in our history. And again, some of them very, very recent. And so I think that, that distrust in many ways is warranted. And I think there's a lot of work we need to do to rebuild trust and to try to create a more equitable system so that it's not, perpetuated, that those abuses aren't perpetuated. We even know, I was reading a study recently, as recent as 4 or 5 years ago, there was a survey of medical school residents, so people who are training to become doctors, and more than half of them still believed in several myths associated with Black and brown bodies. So things like Black people don't feel as much pain or have a higher pain tolerance. And 4 years ago, believing those myths. And so we know there's a lot of work to be done, because obviously that translates into a different type of care that's being delivered. And so, yeah, I think it's very real, it's very warranted, and I think it has implications for a lot of the work we do going forward.
Yeah. Latoya, did you have any thoughts?
Those are the same examples I would have given in terms of the mistrust that you see. And even what's the issue with the OBGYN starting that you see perpetuated and continue today, not only were they experimented on, but they weren't given any anesthetics. And when they then took it over to white women, they gave them anesthetics. And it just continues this trope of the strong Black woman who does not feel pain in the same way someone else does. And it's very harmful. Also, when you think about, I was researching about kidney transplants, for example, where the incidence, the rate where Black people get kidneys, they're not getting it the same rate as someone else would. And part of it was that when I read about it on the kidney.org website and I was looking at what they were saying, they were utilizing this blame the victim concept where they were talking about, well, it's their diet and all these different items. But then there's also a study going on that noticed that the metrics they utilize to determine whether someone can get a kidney was calibrated in a way that Black people looked like they were healthier. So it made them go down on the list for getting kidneys. So simple things like that. Or if you look at environmental hazards, you look at asthma rates for children, you look at what happened in Flint with the Flint water and lead poisoning. Like, these are all concerns, and it causes mistrust because governmental agencies did this. When you look at the environmental health, and Flint was just a couple of years ago. I mean, I think they just said they might have clean water. I think there's a lot of disparities whether the CDC said it was clean water, people don't still trust it. And I think that flows into the COVID vaccine. So today, there's always this conversation about whether you want to get the COVID vaccine. And I know when people were talking about the COVID vaccine, there were families of the syphilis patients were trying to make an argument for people to get the COVID vaccine, because a lot of the argument was what happened with syphilis, but the families are saying, well, that was withholding treatment. But you can see that same fear is still continuing. And I think what a lot of the narrative says, well, people mistrust the vaccines, but they don't talk about the harms that were caused in that narrative to explain why there's this mistrust and how do you regain that trust, make people feel comfortable with getting the vaccines, because people are so used to being taken advantage of for the benefit of others. And so there is that mistrust. And even when you look at vaccine trials, people are not willing to actually volunteer for the trial. So I'm personally going to get the vaccine when it's my turn, but I would have never taken the option to be on the vaccine trial. And that's part of that mistrust that is there.
Yeah, I think it's really poignant because these conversations are happening in real time around COVID-19, and I think that's why a lot of people are being exposed to some of the Tuskegee experiments and things like that, because there's more of these conversations bubbling up. So thanks for tying it into something that we're currently seeing in our communities. Dr. Knight, I know that you had worked on creating an equity guide for public health practitioners and talking a lot about how unconscious bias, white privilege, things like that lead to some disparities in the healthcare system. I think it's really easy for people to say, yeah, testing on people is bad, but these unconscious biases and things like that play out. Could you talk a little bit maybe about what you found and how you were working to educate other people about dealing with those in their practice?
Yeah, so the Health Equity Guide, we were actually on our second iteration. It's a project with the Delaware Division of Public Health, and it's meant to help train existing health professionals, right? So recognizing that people who work in the field, people who were drawn to this field because of a passion for helping people, still hold these implicit biases. And I think that recognition of that is the first important finding, right? So recognizing that those implicit biases exist, recognizing that they're pervasive, right? They're not just in the healthcare system, they're in the education system, right? They're in the criminal justice system, they're across all the different kinds of systems that we know interact in ways that can create or promote positive health or can harm health. And so the idea with the guide is, one, raising awareness about data and what do we know about health inequities, because I'm always struck by the fact that so many people still don't understand or know that there are such big health inequities, first off. So making the data available, but then, talking about why they exist. And why they exist has a lot to do with social determinants of health. And so I have to give my little spiel on social determinants if I can, right? So we know that the strongest determinant of health is income or poverty, right? And we know that, however, income is not a proxy for race, because as Dr. Watson said, even kind of wealthy African-American women have poorer outcomes than poor white women. We know that sort of, there's this kind of complex interaction of income, education, race, all the other kind of identities that we all hold in terms of kind of what our likelihood is of being healthy, or what our likelihood is of getting sick. And so what we've tried to do is talk about the ways in which all the biases and racism, and I'll say racism because I think there's also sort of more conscious and isn't necessarily any more. I mean, implicit bias is subtle. I don't know that it's necessarily any less important or powerful. So I think it's both, right? It's implicit bias and it's sort of more direct racism. But I think what we're trying to do is really raise awareness about the fact that racism in all of these areas, housing, education, jobs, the way we design our communities, where we put our parks versus where we put our factories, like all of those things matter for health. And we need to make decisions. We collectively, policy makers and citizens need to come together and make different decisions, because the decisions we've made up till now have created the inequities we have in health. And so, it's a 200-page document, but in a nutshell, that's kind of what we're focused on. And then we also try to offer some strategies for like, what can people do to make a difference? What are some of the areas that can have the biggest impact? It's a lot of information.
I think it's great. And I appreciate your point. I think with the social factors you're talking about, I think a lot of people, there's a lot of things where socioeconomic status tends to be the key factor in terms of success. But I think a lot of people lean on that as a crutch so that they can ignore the conversation of race and racism, and saying, yes, that is there, but there's also these other things. So it doesn't mean we get to ignore them. And in fact, they all kind of come together and affect one another is really important to be said out there. One of the questions that I do want to ask, and as a reminder, if you have questions that you would like me to ask, send a note to Maria Lilly. She's the host. She will gladly get them over to us. Is talking about the importance of representation. So Latoya, you talked about how I believe you said that there are less Black male doctors now than, I don't remember the exact year that you said, but talk a little bit about the importance of reputation and maybe how it plays into some of the other things that we've discussed earlier in this conversation.
So I think representation is important, not just in the health field, but throughout our entire experiences, because I think when you look at the media, all of these stereotypes you see are reinforced by the media that you see. And then when you go into schools are more segregated now than they were years ago. And even within a school, you have in-school segregation. And so you don't have the opportunity for people to counter these narratives people have in their head. So that's one piece, is not having the ability to counter the stereotypes that you're hearing about other races. So that's one piece. But another piece is, I always say that when I walk into a room, I change that room. And because my perspective is different. And so if you have the right people in the room, they can see these gaps in your thinking and these disparities and what their causes of them are. And so you, number one, have the people in the room to do that, but then you also have to let them not dismiss what they're saying and give them the power to make those decisions. And that's the key issue that we're having today, is that we don't have people in those rooms to make those decisions. And a lot of that is, when you think about the Black males and being doctors, that flow of doctors is cut off very early on. You look at the school to prison pipeline. So you look at suspensions and out of classroom experiences for young males. At younger ages, they're seen as being defiant, as opposed, even though they're normal age behaviors, like in kindergarten. And I've had personal friends who've experienced this issue where their kid was suspended for things that another 5-year-old would have not been suspended for. So the kid was writing with a crayon on the billboard, on the bulletin board, and they got written up as writing graffiti. And they had like a huge file this big. And I laugh it off. It's like an uncomfortable laugh, but it's unfair and it's not right. And so when you think about that, and then as you see going through the school years, our students are less likely to have teachers that look like them. So in the state of Delaware, I believe like in my school district, it's like 25 to 30% Black. The teachers are 6% Black. So where do my kids learn about the ability to have a space they belong in these spaces when they don't have representation there? And then when you go through to see where when they become doctors, they're cut off in the collegiate level and they're not seen in the medical school classes. So you have to think about like representation at all levels, and teaching staff in the classroom in areas of power that can make decisions. And then especially when you think about health, the CEOs of pharmaceutical companies, legislators, both in state as well as in federal, to have that representation to make decisions that really impact us. But also keeping in mind that we have to pay attention to those stereotypes and have those counter narratives to counter the longstanding stereotypes that are really impacting our country. Because our country has this concept of blaming the victim and using terms like Black on Black crime and the welfare mom. And that really continues this narrative that keeps these disparities in place.
Yeah, great. Thank you. A question that was asked, and Dr. Knight, I think you hinted towards this a little bit, and talking maybe about how it all ties together a little bit in terms of access and where the actual physical locations of where people access healthcare and how that relates to some of the racial inequities that come in healthcare. So, where the opportunity to physically go to the spaces to engage in quality healthcare, if you have thoughts on that.
Absolutely. I mean, there's a sort of a tagline that we sometimes use in public health, that your zip code is a better determinant of your health than your genetic code, right? And so it's, if you think about all the things you need to be healthy, right? At the healthcare system, hospitals, access to quality care is critically important. But if you think about all the things you need to be healthy, you need, affordable fresh fruits and vegetables. You need a safe place to play, or, for your kids to play. You need to be able to walk. You need good jobs. You need, clean air, green space. All the things that you need to be healthy are part of our environment. And so healthcare is a piece of that. I would argue that it's a small piece, but it's a piece. It's all those other things in our environment that have just such a huge impact on our health. But absolutely, I mean, we know that segregated communities, particularly inner city segregated communities, have poor quality healthcare if they have access to healthcare at all. We've had issues related to, hospital closings and mergers and acquisitions and all those other things. And so we know that poor individuals, Black and brown communities have less access to quality care, across the United States for sure. But I would argue that these vulnerable communities, or these at-risk communities, these communities that have the higher health inequities, have poor access to all those things you need to be healthy, including the healthcare system, or including hospitals and doctors.
Yeah. Latoya, did you have any thoughts?
I just echo everything she said. And I think another piece is the medical care coverage, because there are gaps in the coverage for Black and brown communities. And if you think about where there's gaps in certain states in the South, they are typically more impacted by Black communities. And part of it is the stereotypes with the welfare concept. So they are not willing to expand Medicare or expand any affordable care funding for those populations.
Yeah, I think what I would like to hear comments on, I think it's not necessarily uniquely a US problem, but insurance access is such a huge part of everybody's ability to access healthcare, is if you have insurance and can essentially afford it, even though, as Dr. Knight said, it's supposed to be a human right, but insurance is a part of that puzzle for everybody. Any thoughts about health insurance and how that plays into this conversation from either of you?
I know for me, I made sure I always had the best in health insurance, and took the PPO option so I could pick who I wanted to see, and it really made a difference. And I'm also happy I live in a state that has a expanded medical care, Medicare for children. So when my daughter was sick, a social worker let me sign up for Medicare for any child who has a longstanding illness can sign up for Medicare. And that would cover any gaps my insurance provided. And so that was really helpful. And so I had the option to get the best care. Now, even with the insurance, having the best insurance, I will say that our insurance in the state of, in the US is problematic because they can deny care for things. So for example, my daughter was denied care for a $400,000 treatment, which is proton therapy. So if anyone doesn't know, proton therapy is, it's a very limited radiation where it's very targeted and it limits radiation to the surrounding areas. So my daughter had botryoid rhabdomyosarcoma of the bile duct, and it was right going through her liver. And so they said that she should get traditional radiation instead of that, and denied the coverage for it. So that's something of concern. I was lucky that her doctors were supportive, and that our Medicare, our social worker said that Medicare would cover it if they didn't end up covering it. So there's two instances there where we have people who don't have the best care, have to go through HMOs and have gaps in their coverage. And you can go actually be poor at the end of this experience, especially when you look at childhood cancer, where sometimes the treatment requires someone to leave their job in order to take care of that child, which is why we're thankful that we have to be positive for that. But also our insurance industry does have the ability to deny care whenever they see fit, which is a problem as well.
Yeah. One question that was asked, and maybe Dr. Knight, you can talk a little bit about this from research if you have some resources. Somebody asked is, how prevalent are these issues in other marginalized populations, Latinx populations, APITA communities, Indigenous people? How does that play out in those populations and other minority populations?
Yeah, so when we wrote the health equity guide, we sort of shared data on all different kinds of communities, and we made a conscious effort to focus on African Americans in the United States because of this history of racism and the health inequities that we see across Black communities in particular are the greatest, and really due to that history of racism. But you can almost any group, and I sort of always hate to sort of talk about groups, because it's sort of these, sometimes we have these stereotypes or these kind of assumptions about group identity, but really from a research perspective, any group that is considered a minority, whether it's a sexual minority, a gender, women, religious minorities, people with disabilities, certainly Latinx, Indigenous communities, any community that is viewed as sort of other in this predominantly white space is at risk for poorer health than the white majority. I mean, and again, it has to do with that sort of issues related to power, access to resources. It's all of those things that make it easier to be healthy. We also know, and there's a lot of research around this, and it's can get kind of complicated, but it's also some of the intersections of those identities, right? So a poor Black woman has, a greater risk for poor health than a wealthy Black woman, right? And so these, or a gay Black man, so these things are sort of complicated. But a lot of it has to do, from a research standpoint, a lot of it has to do with this really chronic stress associated with being, oppressed, being discriminated against. And that chronic stress has physiological manifestations in the body. So there's the issue of access to resources, which we've talked about, and there's certainly discrimination and lack of access to the resources people need. But on top of that, there's sort of this physiological impact of chronic stress that manifests itself in the body as in poor health. And so there's that kind of that combination that happens. And so that's one of the reasons as well that any of these other communities, as you mentioned, do have poor health outcomes. And depending on kind of what health issue you're looking at, whether it's life expectancy or infant mortality, we tend to see kind of variations, but almost, universally, the wealthy white kind of group, right, has the best chances of good health.
Yeah, I appreciate you. Kind of my next transition is talking about the impact a little bit of how this affects individuals and communities, and not only the physiological impact, the emotional impact, and maybe some of the cultural impact that's out there. And we've already talked a little bit about this kind of mistrust that has been built because of this. But what are maybe some of the salient impact points that you all would want to make sure people understand and know about, or outcomes from this inequity that exists?
I think when you think about like being Black, for me, or brown, or any other different group, it's operating through life where you're dealing with microaggressions on a regular basis, and you get used to it. And it can come in various places. And also, like when you think about health, like having a difficulty with navigating dealing with doctors and in doctor speak, or them talking down to you, but also relating it to other situations. And so that's really hard as well. So for me as a Black woman, is believing that I belong in certain spaces, whether I'm talking to a doctor and can have a conversation where they don't talk down to me, don't assume that I'm younger than I am, or that I'm not intelligent, and have to say, I'm Dr. Latoya Watson, so you recognize I'm educated. Or whether I'm going into a store, a simple task of going into a store pre-COVID, and for someone to assume that I can't afford what's in there. And I think it's this ongoing stress of that, or for someone I'm going down the street and someone to make assumptions about me, to have experiences where people use the N-word, and it's never in a situation where it's just a regular conversation. It's always a situation where I feel unsafe. And that's the cumulative effect of microaggressions and macroaggressions and racist issues. It's hard. And for me, a lot of that stress is knowing that I brought my daughters into the world and I wanted a better world for them. And the work that I do is really rooted in that. And the last few years have made me lose a lot of hope that things will be better for them. And it's scary. And that's a big stress. So for me in the last year, I've been focused on not being stressed, because I've recognized after going through therapy, like a lot of the traumas of my life has been rooted in stress. I'm high risk for cancer. I had a daughter who had cancer. My father just died of cancer last year. His mother died in her 20s of cancer. And so I'm really focused on how do I not fall victim to cancer and to let stress take me down. But I think it's just moving through a world where you have to deal with these traumas. And then you also deal with the dismissive behavior of everyone saying that your experience is not valid, or this is not really happening. Or people say that I'm a nice person, even though there's racism, but I'm not a racist, but there's no active work to change things. And that's the hardest part, I think. Moving through the world, feeling like it's not going to change, and always feeling like no matter how much money you make, if you move into middle class, you'll always be a second-class citizen, and you're always at risk for having poor outcomes, whether you're in a health setting, whether you go into a store or go into any location, you can always be seen as second or less than.
Powerful stuff, and thank you for being vulnerable and sharing that with us on here again. It's very important for people to hear that perspective if they've never heard it before. So thank you, Dr. Watson. Dr. Knight, did you have thoughts on outcomes and impacts that you would want to share from research or your work?
Yeah, I often like to share research, and sometimes I say because it validates that personal story, but I don't need to validate your story. I mean, it's valid, right? And so, sure, I could share lots of data, but I think what Dr. Watson shared is really powerful, and I don't think I can add to that.
Excellent, thank you. Somebody asked specifically maybe if there's information that you could share about how this relates to mental health care access or the mental health field in general. I didn't know if either of you had thoughts or comments on that you would want to share.
Well, I mean, all the same access issues, whether it's insurance, having access to insurance or being able to afford care, exist in mental health. More so, frankly, than what we call physical health, right? Although our heads are attached to our, but I think there's this added challenge, or due to the stigma that we still have not been able to sort of undo with respect to mental health, mental well-being. And again, the research shows us that Black men in particular have a hard time seeking care and things like that. I would again argue that the system itself is what needs to change, not the individual seeking care. But I think all of the same issues exist. I think that we've made some progress in terms of making where people do have insurance. We've made some progress in terms of making access to mental health services on some par with other kinds of health services, but where we have access barriers, we still have access barriers. So it's not particularly different in that regard.
So when I think of mental health care, I know everyone watches This Is Us. That's my show that I watch to cry all the time. But more recently, Randall had to seek mental health care, and he switched to a Black male mental health therapist. And that really speaks to when you have the access to mental health is, can you find a person of color who understands your experience? You don't have to explain that other layer. It's understood. Because I think if you, and it's not saying that you can't have someone who's not of color and be a therapist, but in some cases, especially in his situation, where he was dealing with racial issues within his own family and moving through life as a Black man who was adopted by a white family, there's certain things he doesn't have to explain with the Black therapist, and they can move through the conversation differently. And I think that in itself is a challenge. The representation in the field is not there.
Yeah. As we start to wrap this up, one of the questions that I think I really appreciate whoever asked this, we have undergraduate students on here, and I think we can both agree, we're talking about very big, deep-rooted problems, right? And very deep-rooted issues that exist not only in healthcare, but in America and in so many other systems. Somebody asked, what can I practically do as a student, to move this forward? What things can I do other than, advocating for legislation and law? Like what can an individual person do to help maybe tick the needle on these things?
I think part of it's at the core of it, when I look at equity and structural issues, is the mindset issue, because so much of the work that when you look at research that's done or work that is out there, is very deficit minded, meaning that you're always looking at what the person did to deserve to be in that situation. So it's their Black on Black crime and all those that type of thing, but not really looking at the institutions itself. But as a person, looking at your mindset and and really challenging those type of thinking. And so when you see narratives, are you, for example, if you're listening to music, if you listen to Black music, are you only listening to little whatever? I'm too old for that generation to know the names. But are you only listening to that? But are you listening to broad spectrum of music? Or when you see visual images of Black people, are there a varied image? Because too often we get very stereotyped tropes and we don't realize that we internalize that. And that's where the implicit bias starts to come into play and work. So that's one little thing that you can do. Another thing is just do the work, to do the research on your own. Don't expect, if you have Black and brown friends, for those people to do that work for you, do the research for them. And also a lot of times when I go to meetings at work, Adam sees me at meetings all the time. I am quick to, if I say something, it's really helpful to have an ally who raises their hand and amplifies my voice and says it as well. It adds to my perspective. And so in your classes, when you're in a classroom, we are at University of Delaware, I'm a UD alum. I was in classes where I was one of 2 Black people in the class. I had to sit in the class where the teacher said that slavery was an accident of history. And the teacher, there was also when it was 10 reasons against affirmative action, and all of them were racist reasons. And he brought the newspaper would not run it. He brought it to class. And I said, I think this is inappropriate. And no one came to my support. And that was 20 years ago. And I still remember that with vivid imagery. And so if you are not of color, to support those who are of color in the classroom and affirm them in the classroom. And if you see someone in the classroom, there's only 2 Black people in the class and you see them sitting by themselves, say hello and be supportive and don't let them feel isolated, because that happens a lot. And so going to college is hard. Being at a PWI when you're Black or brown is even harder because you're isolated and you have to deal with situations where some people act as if you shouldn't be there. And so being supportive in the classroom is really important in that way. And then when you go out into the working world, whether you are wherever you work, to do the same type of work. That's the basic level thing you can do. And also call out your family members if they're saying things that are problematic. I know I've seen a lot of online. I try to filter it out where people are saying, well, my family member believes this, and I don't know how to have that conversation. But you have to have those difficult conversations. It's not easy. And I always think about, like, I'm Black. And so there's a lot of issues with LGBTQ in the Black community, and Black transgender women they are killed at a very high rate. And so that's an uncomfortable conversation. I'm Black, I'm also from Trinidad. So in the Caribbean, it's really bad as well. And I say something every time. And that's an example of how it looks like for me, but in your families, it may be about race, and you will have to call it out, because that's how we make change. Those little things. I think sometimes we think you do something really grand, but it's what you do in the classroom, when you go into the working world, when you have to hire people, have that opposing voice that says this is how you hire. Don't say someone's not a right fit. It's that, and it's a lot of it, it's the mindset. You have to shift your mindset, be very aware, challenge your biases, and do the work, and be supportive of your Black and brown friends and colleagues.
Yeah, thank you for sharing. Dr. Knight, did you have any tips for our students or things that you would want to throw out there?
Yeah, I mean, I think Dr. Watson kind of said it all. I mean, the only thing as a coming from my perspective, the one thing that I also do or try to do, and I probably still, miss the mark sometimes, is just keep challenging myself, and because I do believe we all hold implicit biases. And so I think doing the work and really sort of being reflective, and there's all those things you need to do that we all have to do, kind of that Dr. Watson mentioned. I think one of the hardest things to do is to do some soul searching and do that inner work yourself. And so for me, that's the practice that I've been kind of focused on most recently, because there's still lots of work, still lots of work to do.
Awesome. Well, I want to say thank you to Dr. Watson and Dr. Knight for spending time with us this afternoon and lending your voice, your perspective, and your story to this important conversation. I think that as a UDance advisor, I was excited when they said they were like, we want to have these conversations. Who should we ask to do it? And I'm like, we got people in our backyard. I know we do. We're at UD. There's people here that can do that. So thank you so much for sharing your evening with us. And I am going to turn it back over to Sarah and Maria, the executive directors of UDance, to close us out.
Thank you. Just to reiterate what Adam just said, thank you both so much, Dr. Knight and Dr. Watson, for having this discussion with us. We're really grateful to have UD professors and faculty and staff who do push us to be more educated in hopes of a more inclusive community. Additionally, thank all of you guys for coming out tonight on this Monday evening. We really do appreciate you all being a part of this conversation as well. Additionally, we do acknowledge that as an RSO, this is one of our first steps in making positive changes within our community. We're continuously learning and challenging ourselves every day to be a more inclusive and diverse community, not only at home, but also externally as well. These are important and sometimes uncomfortable conversations to have, but ones that we also continue to look forward to having in the future.